shared.
Thank you.
Mm-hmm.
Yeah, go ahead. Go ahead. I'm very happy to the organizers to have finally invited Zim NITAG, that's our acronym for Zimbabwe NITAG, to this very important series of webinars. We missed the two previous ones, but yes, I've been listening to some of the presentations and very, very useful. My job really has been made easier by the previous presenters, Abigail, CD, and Prof. Anita, sorry. Is it Anta? Sorry. Sorry if I pronounced it wrongly. We in Zimbabwe have, I'll tell you the story that we've gone through in our process. If people have to take away a message today, we did not have any problems with technical information or the processes. We made a decision 2 years ago. Our problem is implementation. So we'll go through and discuss some of the issues without going into too much detail about the whole process. I think by now people more or less understand the roles and responsibilities of NITAGs. Next slide, please. So that's our story. Zimbabwe NITAG was formed in 2011. Were re-established in 2016. And like I said, we've got the required expertise as per WHO guidelines. We have the ex officio liaison secretariat as per recommendation. We have the luxury of having extra, what we call NITAG coordinators. We've got a librarian who is very useful in assisting members in doing a literature search for whatever topic we attend. And we also have not secretariat, but a human being, a secretary, who is actually a retired EPI manager who, with the librarian, they assist in arranging meetings, taking minutes, and also giving feedback to all members. Next slide. I think there's a delay in the way the slides are changing here. Have we gone to the next slide?
Yes, the slide titled HBBD presentation.
Oh, okay. There was some issue about funding. I think it's important to maybe other countries who haven't started their NITAGs, because people need to know how we are sustaining ourselves. Setting up a NITAG is the most difficult, or maybe also most expensive. The running costs are minimal. We are housed in the central vaccine stores, so we don't pay any rent. We had the initial trainings and orientation, which were assisted by the CIVAC initiative. This was to train the members on evidence-based recommendations. We had 2 trainings and an inauguration meeting. We also got assistance from Gavi to get us office equipment. We've got an address, we've got a physical space that we occupy, so we needed some furniture, and also a laptop, which is the one that I'm currently using. The running costs really are for meetings, be it local or international, in terms of capacity building for our members, both core members and liaison or ex officio. The coordinators are on a small stipend, which they get from funds from Gavi, and they are part-time because most of the time there isn't much to do. Next slide, please. Again, looks like there's a bit of a delay. But the recommendations that we have done, we have made as NITAG, we are recognized by the ministry, except maybe I can preempt, maybe the only issue is the COVID-19, where they have parallel structures. We'll go there on the last bullet. But for most vaccines, they take our recommendations. There is no recommendation that has been rejected by the Ministry of Health. And for the HPV introduction, this one was our first real technical output. And we made sure we did it properly. The hepatitis B birth dose, sorry, that is the one in 2018. Hepatitis B birth dose was our first one. It was done, I should say, very well. We also had the HPV introduction 2018, TT to TD, TD schedule 2019. We introduced the TCV 2019, but because of COVID and all other issues, things were postponed and we only launched it recently after a lot of postponements. And we have the IPV first and second dose. We also have managed to switch rotavirus vaccines from Rotarix to Rotavac. This is mainly to do with a switch for sustainability as we are graduating from Gavi eligibility. So we looked at the costs and many other factors. I did mention the COVID-19. There's an expert advisory committee, and they have been having more influence on the decision. Sometimes as NITAG, we only hear either as press releases or somewhere that this is the vaccine that is coming. So those are the vaccines that we are using for COVID-19. And currently we're working on the Johnson & Johnson vaccine. This one, our ministry hasn't decided whether we need it on board or not. And we had a meeting yesterday, and we're currently compiling all the information, and we should be giving the ministry advice by Friday, tomorrow. Let's have the next slide. So since September 2018, this is 2020, we made the recommendation, followed the process, produced the technical dossier, which was taken to the then permanent secretary. In other countries, you call that the Secretary for Health. And but since then, nothing has happened. We're still one of the countries that have made a decision, but implementation is still zero. So in terms of the technical issues, I'll go briefly. This has been mentioned by previous speakers. What generates a NITAG agenda could be from regional or global recommendations. At that time, it was from the RITAG. The hepatitis B birth dose was topical. And we did the whole process, like Prof said in a previous presentation. We had a technical working group, and we used the typical recommendation framework where we looked at those 4 areas: burden of disease, vaccine and immunization characteristics, economic considerations, logistical and programmatic. Without going into too much detail, one thing I will mention is that we had an advantage because institutional versus home deliveries have been hovering around 84 to 90%. Of course, affected by COVID and user fees and all other factors. So we had that on our side, because if most or a significant number of women are delivering in institutions, we could actually manage to give the first dose of hepatitis B within the required 24 hours. We looked at vaccine safety, efficacy and immunogenicity, cold chain logistics, and co-administration. Some of the drivers for this program to take off is obviously availability as a monovalent, vaccine costs, sustainability, depending on the source and the cost, and also other hidden costs besides just the vaccine costs, training, and like I said, other hidden costs. The ability to give vaccine within 24 hours, to train people in the labor ward who don't normally give vaccines, also acceptability to the people and also to the mothers. Our source of information was obviously internet-based databases, PubMed, Cochrane, and also Hinari, WHO position papers, and SAGE recommendations, and obviously local data when available. Next slide. So the process, I think it has been mentioned, is when NITAG makes a recommendation, a technical dossier is presented to the policymakers. Starting in our situation, the secretary, or permanent secretary, now the names have changed, we call them Chief Director of Preventive Medicine, who then takes it to the minister himself. And this is where we start having issues or problems. Because at that time, they thought, oh, lovely, this makes sense, but it's not a priority at the moment, which maybe at that time was debatable. It was before COVID. But at that time, we were having different set of, there was a lot of change at the top management team. We mentioned it in some of my challenges, where we would have permanent secretary changing, and don't want to make any commitments, where you have the minister also changing, a new team comes, and in the end, no one was committing. Even the Ministry of Finance was not committing to take this on board because they thought it would not be sustainable. And at that time, and I think it is still current, that the Gavi board said they will not support the financing of the vaccine costs, which depending whether it's a multi-dose, 5 multi-dose or 10 dose, the price changes. But no one was committing to actually getting this vaccine on board, because again, going through Gavi transition. Next slide. So this has been our story, and to me, I would say frustration, because we're almost getting to 2 years down the line, and we still don't have implementation of of a recommendation that was made in September, 6 September 2018. So some of the challenges that first, besides the decision at another level, which are the policy makers, from the technical side, we really wanted to do a prevalence study to really find out the prevalence of hepatitis B within the first 6 weeks. Because basically the literature, everyone is saying, yes, by the time you are 6 weeks, a lot of children already have been infected. We know we've got more of vertical transmission in this part of the world. We have some studies that were done. These were old studies, maybe outdated actually, and we couldn't do the seroprevalence study, but as part of our recommendation at the end, we actually recommended that at some point, I think it should be done, but we can make a recommendation at this stage. Just like we all know, the strength of your recommendation is also influenced by the strength of your evidence. And without any doubts, the non-committal from the policymakers, from the ministry, government officials, was too much reliance on Gavi support. When they saw that Gavi is not doing this, maybe it's not a priority, maybe we're not ready, and that will be almost like that's where it dies, this issue of introducing hepatitis B birth loss to our newborns. And there were too many changes in the top management team. It was difficult to follow one thing that you had discussed and agreed on with one previous minister or permanent secretary. So it's really frustrating. Next slide, please. Finding the evidence is important. That's what NITAGs do. From SAGE to NITAG, when it's now at the NITAG level, you should have available data, because this is what drives you. This is what gives the community confidence, or even the policy makers. They'll get confidence if you are using the data that is collected from the people in the geographical country. Funding issues. Yes, that needs to be very clear, and people should take ownership. Government should take ownership rather than to rely on external, this particular case, Gavi funding. Programmatic issues, lessons learned, yes, we're ready. We made a plan from our recommendation framework how to deal with some of these issues. And the major thing, because all these lessons learned, one is feeding into the other. Just like the issue of sustainability. Once you commit, depending on your GDP, GNI, once you commit, you should be able to sustain. And all these ministers and chief directors, they were taking responsibility, making a decision, because they didn't think that the country will be able to sustain this program. Next slide, which just says thank you. This is the story of Zim NITAG. And like I said earlier, technically, we were okay, pass the baton stick to the other side, and then implementation is 0. Thank you.
Thank you very much, Dr. Gonah, for excellent presentation and really describing the relationship between the NITAG and the Ministry of Health and that